Welcome. In this video, we will explain infective endocarditis in simple language, how it starts, what it does inside the heart, how doctors diagnose and treat it, and what recovery and prognosis can look like. Infective endocarditis is uncommon, but it is serious. It means that germs, usually bacteria, have infected the inner lining of the heart or one of the heart valves. Your heart valves work like one-way doors, keeping blood moving in the right direction. Normally, the bloodstream is very well protected. But bacteria can sometimes enter the blood from the mouth, infected skin, an intravenous line, injected drugs, or certain medical procedures. In most people, the immune system clears them. But if a heart valve is damaged, artificial, or has rough surfaces, bacteria may stick to it. The key event is attachment. A tiny rough spot on the valve acts like a landing pad. Blood clotting material, called platelets and fibrin, can collect there. Bacteria attach to that material and hide inside it. Over time, this forms a clump called a vegetation. A vegetation is not a plant. It is a mixture of germs, clotting material, and inflammatory debris. It can interfere with the valve, damage heart tissue, and shed infected pieces into the bloodstream. This is why endocarditis can affect the whole body. If the infection is on the left side of the heart, tiny infected fragments can travel to the brain, spleen, kidneys, or other organs. This can cause stroke, abscesses, or organ injury. If the infection is on the right side of the heart, fragments can travel to the lungs and cause infected lung clots. The infection can also eat into nearby tissue, causing a heart abscess or electrical conduction problems. Symptoms are not always dramatic. Many people have fever, chills, tiredness, night sweats, weight loss, new shortness of breath, or a new heart murmur. Some have small skin spots, painful finger or toe spots, or tiny lines under the nails. But these classic signs may be absent. The most important message is this: unexplained fever in someone with a prosthetic valve, previous endocarditis, certain congenital heart disease, or a heart device should be taken seriously. Diagnosis usually combines blood tests and imaging. Doctors try to take several blood cultures before antibiotics, because the cultures help identify the exact germ and the best treatment. An ultrasound of the heart, called echocardiography, looks for vegetations, valve damage, abscess, or prosthetic valve infection. The ESC guideline recommends transthoracic echo as the first test in suspected endocarditis, and transesophageal echo when the first test is negative but suspicion remains high, when a prosthetic valve is present, or before selected patients switch from intravenous to oral therapy. CT, PET scans, white blood cell scans, brain imaging, or whole-body imaging may be used when complications or prosthetic material are involved. Treatment is urgent and specialized. Most patients need intravenous antibiotics for weeks. The exact antibiotic depends on the germ, the valve involved, allergies, kidney function, and whether a prosthetic valve or device is present. Native valve infections may need 2 to 6 weeks of treatment, while prosthetic valve infections usually need at least 6 weeks. Current guidance emphasizes care by an endocarditis team, cardiology, infectious disease, heart imaging, microbiology, cardiac surgery, nursing, pharmacy, and outpatient antibiotic specialists. Antibiotics are the foundation, but they are not always enough. Surgery may be needed if the valve is failing and causing heart failure, if the infection is uncontrolled, if there is an abscess, if bacteria remain in the blood despite treatment, or if a large vegetation keeps sending clots. Emergency surgery may be needed within 24 hours when severe valve damage causes shock or severe lung fluid. Urgent surgery within a few days may be needed for heart failure, local spread, abscess, fistula, enlarging vegetation, or high embolic risk. If a pacemaker or defibrillator system is definitely infected, guidelines recommend complete system removal without delay. Prevention focuses on reducing bacteria entering the bloodstream and finding infection early. The AHA emphasizes good oral hygiene and regular dental care. Antibiotics before dental procedures are reserved for people at highest risk of poor outcomes, such as those with prosthetic valves, previous endocarditis, certain congenital heart conditions, some valve repairs with prosthetic material, or transplant-related valve disease. Clindamycin is no longer recommended for dental prophylaxis. For many non-dental procedures, antibiotics solely to prevent endocarditis are not routinely recommended when there is no active infection, although the AHA has called for renewed attention to risk after some non-dental invasive procedures in high-risk patients. Prognosis depends on how early endocarditis is recognized, which germ is involved, whether the valve or a device is infected, and whether complications occur. Serious complications include heart failure, stroke, abscess, kidney injury, and relapse. Outcomes improve when blood cultures are taken early, the right antibiotics are started, infected hardware is removed when needed, surgery is performed at the right time, and follow-up is close. After treatment, doctors may repeat blood cultures, monitor the valve, teach prevention steps, and support recovery. If injection drug use contributed, addiction treatment is part of heart care. The takeaway is simple. Infective endocarditis is rare, but it can be life-threatening. Early symptoms can look like a regular infection, so risk factors matter. If you or someone you love has a high-risk heart condition and develops unexplained fever or feels very unwell, seek medical care quickly. Early diagnosis, expert treatment, and careful follow-up can save lives.